Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hey listeners, I value you being here. Please, I encourage you to leave a review. I'm going to be reading out a review each month, and that person can have a one-on-one call with me to have a chat. And I think that is a great way to reward you as a listener. Also, as you like and subscribe to this podcast, it helps get our message out to other physicians and clinicians who are struggling. Thank you so much for your reviews, and I look forward to reading them out here on the podcast. Hello and welcome back, everybody. Today we have with us Marcia Kashani, and we are delighted to have a chat to you about all the things you're doing in regards to things like access improvement and other optimizations in our clinical day. So welcome. I'll let you introduce yourself.
Thank you, Sarah. My name's Marcia Kashani. I'm a nurse by background. I've actually worked in a family doctor's office, an academic teaching clinic, at the time that they were implementing an EMR. So familiar with going through that challenge of change. From there, I ended up working with our zone in Edmonton, setting up primary care networks. So in Alberta, they were trying to strengthen primary care and asked physicians to look at joining primary care networks. I helped sign physicians on letters of intent, and then helping them with their business planning and getting set up, and then was on their governance over time. Out of that work, we had learned a lot through the Institute for Healthcare Improvement and working with Dr. Mark Murray and Associates out of the United States, looking at office practice, or what we called office practice redesign in the beginning, and then it became Alberta AIM. And that was access improvement measures, and started trying to help physicians look at what they did in their practice, how could we help them to be perhaps more efficient and improve access for patients, as well as ultimately improve clinical care for patients. So I was a facilitator for different improvement teams in primary care and specialty care teams. Also then became a faculty. I was the first non-physician, we didn't know what else to call it, but non-physician faculty in Alberta for teaching AIM collaboratives. We taught many AIM collaboratives with multiple teams from across the province. And so I spent many years doing that sort of work. I'm also an improvement advisor through the Institute for Healthcare Improvement, took that course as well. And also have most recently been working with primary care networks again, looking at some of the transitions within Alberta and some of the changes that are happening in primary care. Still the same issues that were there before. Referrals into specialty care is challenging, how to use your team effectively, and access and clinical care are still issues for people. So that's kind of the background for me. I've also worked in acute care, home care, other areas within health in Alberta for a long time. So nice to meet you.
It's lovely to have you here. We're really delighted for your wisdom here. Can you start us off with some of the maybe success stories or some of the lessons that were really powerful that that you've been part of implementing within a team? Just think it's nice to understand what it is that can happen when we're starting to do some of this work. And so maybe starting with a story of success could be helpful to help us understand how this could be put into action.
Sure. I can give you a couple of examples of things that always stood out to me. Certainly whenever we worked with physician teams, most often physicians told us their panels were too big, they couldn't take any new patients, they were too busy. And for many physicians, that meant going to bed at night and not feeling confident that all your work was done in the day, or had you missed something, or, people didn't have any work-life balance, didn't get lunch, whatever that might be. And so what always stood out to me is that as we helped physicians see how you could use other team members, looking at efficiencies in your office, really culling looking at your return visit rates, how often patients come back, how many patients do you really have on that panel, because maybe some of them have moved, and all those sorts of strategies. Eventually, after doing some work to get things organized, they could do today's work today, and they could ultimately take on new patients. So that was always so exciting to me to see that, from going from, no, we're overwhelmed and too busy, to, oh, maybe we could take a few new patients. One of the other really interesting success stories we had was a solo practice primary care physician. And as he did the work with the small team that he had, he realized he could actually afford, if he set his clinic up, to be able to hire an RN himself, not through the primary care network, but hire his own RN, that he could afford to do that and have her do a lot of the other pieces that he didn't need to do, so that he could see effectively more patients and improve his clinical work as well. So both of those are interesting examples of, using different strategies can really make a difference for people.
Yeah, and I think it's important to show that difference of starting to divide up what is physician work
Oh,
and
yes.
clinical clinician work and what isn't, and how
Right.
to start to move that off your plate so that you can get your work done, but not
Right.
be full up of all the not physician work. Um,
Exactly.
that's that's still tricky though, because
It
physicians
is.
know they can do it and they have been doing it, and to trust or train somebody else to do these things becomes really one of those difficult guards to drop. Can you help us understand why is it that we want to do that, and how could we even possibly consider it?
You're right. Like I said, things over how many years of starting this work with primary care networks and embedding team members, I still hear physicians say, what can they, what are they allowed to do? What happens on their license versus my license? What's the difference if they're not licensed health professionals? All of those sorts of challenges. And then how do I find the time to teach them if they don't know something? And it's an ongoing challenge for, I'm sure, for the team members as well as the physician and ultimately the patients. And having people doing the right work can make a big difference in the clinic when it comes to being able to get your work done today. You need to know which pieces someone else can do. And I mean, we had a team in Leduc that they wanted to work on their screening for mammogram screening and fit testing and those things. Well, they actually realized that their reception people could do a lot of that work. They could phone the patients. They could go through the list. They could print a report that said, here's how many patients should have had a mammogram above a certain age, and here's how many are overdue. And they actually started phoning those people, and then were allowed to say, come and pick up the rec. The doctor could fill out the rec, and then the patient could just come get it and go get it done. And ultimately that improved their screening rates. It also actually contributed to job satisfaction for the receptionists. They felt like they were having a positive impact on patient care. And so it made them more happy about the work they were doing and how they were able to contribute. And so I think, we've had a lot of conversations on the teams that I've been working with in the last year about this whole idea of team-based care. And the challenge for physicians are used to being sort of in the middle. If you look at the whole picture of the patients and the team, often the physicians are kind of the middle, and everything has to go through them. And trying to help them to see that they should be on the outside and the patient be in the middle, and different people can each take their part. And some of it's what you've learned, some of it's that comfort in asking what other team members can do. In some cases, right, just because it's within a nurse's ability or in their license practice, scope of practice, you might have called it, doesn't mean they know how to do it. So when I started working in a family doctor's office, I hadn't syringed ears before. I hadn't done a well baby check before. I hadn't done a prenatal exam before. And luckily, the nurse I was taking over from was able to show me those things. If you're in a clinic where it's physicians and there is no other nurse, then somebody, how do you find them that support, right? And I think physicians that belong to primary care networks might have other supports there for those nurses, or can they get that support, the nurses, from a different clinic if you have partner clinics or those sorts of things. So it is a challenge, and sometimes I think it might be sort of that short-term pain for long-term gain. If the doctors could take the time out of their busy schedule up front to teach somebody to do something for them, in the long term, it's going to save you a lot more of your time and make it sometimes, in some cases, easier for the patients to get things done too. So I think it's, you know, trying to have that conversation of who are you, what skills do you have? Are there other things you could do? Is that within your scope? If so, is there teaching you need? How confident are you with those skills? And then if it's somebody who's not a health professional, then you do have to have that comfort in having you taught them and you know what they're doing. So I think it can add quite a bit though.
Yeah, yeah. We had a moment where we had the nurse in the clinic, but it was bottlenecking at her station to get everybody's weight and height and blood pressure done before they came in for their visit.
Right.
Only certain visits needed all of those things done, but still. So we, through what we'd learned through AIM, had her kind of document what she was doing in the day. And we
Right.
realized that she was busy doing all of these, organizing ultrasounds and x-rays for people. And it wasn't nurse work. We could absolutely hand that off to somebody else to increase her ability to do nurse required work,
Yes.
and then give this other job to somebody who didn't need to be weighing and measuring patients.
Right. And it's a challenge because you want the physicians to be able to hand over what's not physician work, because where physicians add the most value, unique and special value that they bring, is in when we don't know what the patient's coming for. We need your expertise to figure out what's going on with them. If they're coming back on a regular basis and you know why they're coming back, that's probably nurse work. But if the nurse then is busy doing other tasks that maybe aren't even nurse work, how do you move that again to either other team members or including the patient as part of the team? Because I think sometimes we're doing work that the patient maybe should be doing as well. And how do you, and mapping that out can be a good strategy to understand what does everybody do in a day, or logging what they do in a day to try and find out more about what's happening in the clinic so that you really know the picture.
Yeah. Taking that example another step further, there was we had a staff member calling the patient saying that they needed their XYZ ultrasound, then calling the ultrasound place, making the appointment, calling the patient back. Patient said, I'm not available that day.
Yeah.
And we're like, wait a minute. When you actually observe this going on, you're like, why are we paying staff to do that? That's exactly what the ultrasound staff are being paid for. So we
Right.
started sending that ultrasound through to the ultrasound place saying, please contact the patient to make the appointment. Boom, that unlocked so many minutes of staff time.
Right. You don't realize how much time you might have within your whole team if you look at things that don't make sense or aren't adding value into the system, right?
Yeah, yeah. That question of what are we doing that we don't need to be doing, and what can you see needs doing that we could start doing? What would add so much value here for our patients? These types of questions meeting together can start to unlock some of the wisdom from the rest of the team and other people.
Exactly. And I think too that you know, what pieces are we doing that we don't need to do? If there's a lot of duplication or double checking of things, so somebody does something, but now I double check that it's there, that's also a challenge. So going back to when you said you documented things, if teams actually have things documented along the way, and you know that, and everybody follows the process, you know that step's already done and you can take those pieces out. And it saves that extra time as well, of that redundancy of double checking, or somebody else is already doing that you didn't even know.
Yeah, yeah. We've talked a couple of examples of, I can already see how you would have less visits back to the doctor per year if the receptionist was giving that mammogram requisition to a patient. That patient's now not having to make an appointment to get that with the doctor. And
Right.
if the nurse is doing a well baby check, perhaps that either reduces the time the doctor needs in the room, or perhaps that's one less visit to the physician that year for that patient. Is there other, because that sounds like it's going to then free up some of those appointment spaces. Tell us more in other things that you've seen that can help with that return rate to the
Sure.
physician or the clinician.
You know, Sarah, I often talk to physicians about what we call the return visit rate. So, right, there's only so much physician supply, and there's all this requests coming in from patients to come and see you. And I can't increase if you're only there for 8 hours a day max, then I can't put more patients in than that. But if you take a look and say, well, on average, your patients are coming back 4 times a year, and let's say you have 1,000 patients, that's 4,000 visits you need in a year. If we could reduce on average to 3, all of a sudden you have 1,000 visits. So that's where you can find space to potentially take on a few new patients, or there could be patients who are waiting that aren't getting into you for clinical things that they needed. And so now they would have better access. So trying to understand clinically, do they need to come back all of those times? Are there options, right? Could phone visits, it might make it quicker, for example, so that it takes less time, like you said, using the team members for those kinds of things that don't need, again, it's going back to what's doctor work. And if you're filling out recs and filling out, doing blood pressure screening or diabetes follow-up, that a nurse could have that same conversation with patients, it pulls them out of that lineup. So if there's clinical things that you've already diagnosed, and clinically the patient is able to reduce that number of visits. So sometimes doctors give you 3 months of a prescription and say, I'll see you in 3 months. Now, sometimes there's a good clinical reason for that. It's new, you're assessing, you want to make sure it's effective, that sort of thing. But a year on, when you know that, do they need to come back every 3 months to keep getting the prescription refill, or could you give them longer? So that it means, and even reducing that to every 4 months is 1 visit a year. So looking at how often you do prescription renewals, or how you do those, and is there a different way that could save a visit if it's clinically safe to do, or what screening are you doing in those times, or bundling things. So if a person comes in because they've got knee pain, but if you can look and say, geez, by the way, I notice you haven't had a physical. Is there a way to do some of those parts of a physical in that visit, rather than saying, go out, no, come back and book another one? Or at least saying, oh, you're due for these screenings. Here's the recs right now while you're here, so that you aren't generating further visits. And I know doctors somewhat kind of like that waiting time and that almost like inventory of patients that are going to come in because they feel like there's business. I haven't, in Alberta anyways, run into people yet where there wouldn't be business for a family doctor. There's a lot of business out there. There's a lot of patients that can't get in, or they're waiting. I personally had a family physician that it took me months to get just a short appointment with her. And So you've got all these patients that are out there that you don't even realize. So if you could get rid of that inventory and see them in a more timely way, it would be getting all those people in. So I don't know if I answered your question, but there's a few options there for trying to reduce that visit rate that would allow you to fill it up with all those people that are out there waiting. So
Yeah, I think that one of the biggest areas that I see difficulty for physicians at the moment when their next available appointment is in, like you said, 8 weeks away. Now, when I'm seeing this patient in the room, if there's an 8 week wait till I can get them back for a routine visit or to check up on this new medication, now you see the pressure put on the physician to say, well, if I can't get you back for 8 weeks, I better dang look and see if your diabetes is up to date and if I've got your
right.
meds up to date. And they're adding and adding and adding all these things to a visit, and they're compounding the work for that visit and how long the visit's taking. And so they're having this rolling effect of, I'm running late. I've got too many things being done in the room. So now my charts aren't done and I can't get them back for 8 weeks. So they've got a list because they know they can't get back in for 8 weeks. And there's got to be some sort of give in this system because I can't do it this way anymore. And so we're saying, how do I get my access improved so it's not 8 weeks away? I could see them next week would be delightful, right? So we're just saying, what do
Right.
you want? What are you yearning for? And I think
Right.
the people coming to this conversation are saying, how do I make my next week available? How do I find some availability next week for these things that I need to see? And so this is what we're trying to say is, what are you yearning for? If you are sitting there twiddling your thumbs with no one to see, this is not the strategies for you because you want to see them back all the time so that you're generating business. But certainly in Canada right now, that is not the case.
Right.
You've got physicians with 8 week wait times going, there's too many patients and not enough of me. I don't know what to do. I'm yearning for a bit of relief here. I need a break. I need a reset on my on my access circuit so that it's not just this massive visit every single time, every patient. And so I've certainly been in this situation. I had to drop my visits by 50% because we had to take up increased hospital time. So if there was less
Oh,
doctors in
yes.
town, so I'm picking up now emerge visits, and I can't just drop half the patients because there isn't this magical new doctor coming to take over those visits in the clinic. So now I've got basically half the appointment, same number of patients, and you're like, uh-oh, we're about to have crisis. It's how can we start to take off your plate some of these things so that not
Yes.
every patient's coming back every single time to see you and you're the only one who can do this. We're saying, how do we use this team? How do we use
Right.
anyone in your circle of influence? Yeah.
I think the team is one of the biggest keys there, and trying to work through how you can use that team more effectively makes a huge difference
Yeah.
for sure.
And even getting creative, because I hear from physicians and clinicians in our office, I have two people, the receptionist and my one MA, so they're just as stressed as me, right?
Right.
Or I don't have any hiring power, and this person's been told they can do this for me and not that, like X and not
Oh,
Y, right? So we've got
right.
no, potential influence or strategy about that. So then it's even looking at who's in the neighborhood for this patient, who else is involved in this patient's care, who could be helpful to us. And it
Right.
could be this patient's wife can take their blood pressure for you. And that
Yes.
doesn't mean to be a visit. It could be this rural pharmacist is brilliant and they'll go through all these meds with the patient in fine detail. I know I trust them, so I'm going to send you down there to talk about this new medication. It's going
Right.
to save some minutes in the room.
Absolutely. There's lots of other team members. Is home care involved with them, and what are they doing, so that again you're not duplicating something they're already doing? If they're checking blood pressure every time they go, then you don't always have, right? If you can get those results from them, can patients do their own blood pressure? Lots of pharmacies can do the blood pressure for people now, right? And there's pieces that pharmacists more that they can do in Alberta anyways, there's a lot more that pharmacists can do for people now. And so how do you use those other team members beyond just what's in your clinic? But even helping that, even if you only have two, what are they doing? And again, is there things like those, calling for appointments, and then it doesn't work for the patient, and getting in the middle of those, whereas you could send them on and have the patient booking directly with the service and not getting in that middle, because that does take a lot of time that you could be doing something else.
Yeah,
for sure.
yeah. So how do we start the conversation with our teams? What are some of the strategies that have come in through the learnings around this team-based care models and things?
Good question. I think that, right, I think it depends. If you're a solo physician and you're the owner of the practice, you can have a team meeting. If you're a group of physicians and someone else owns the practice, then I think there's that discussion with whoever is in charge. And it depends how much say the physicians have over what's happening in their clinic, and how do you have that influence, right? So, I mean, a lot of clinic teams have team meetings where they can talk about how's that going and what are we doing, and are there improvement teams within your clinic or within the primary care network? Are there supports external from your primary care network? In Alberta, we have the AMA Act team that might be able to help some of those kinds of, or have online resources to how to access or have those sorts of team conversations. A lot of the primary care networks are having those team-based care resources that are available to people to have those sorts of conversations. I think it's always good to try to get to know the people you're working with and talk to them, because I'm always surprised how many years later that I still hear from physicians, well, I don't really even know what the nurse can do. And well, maybe you could ask them what they can do, and maybe they would have some ideas of what they'd like to be doing. Because again, if they're going along doing a lot of these routine things that aren't adding a lot of joy to their work, and you said, well, what kinds of things do you see that maybe could be delegated to someone else, but what also do you think you could be taking on that would improve patient care? I bet you they have ideas and nobody's asked them. And lots of them want to share how to make it better. And if you can have your team engaged and they're liking their work more, you're going to get more out of them in the end if people are enjoying what they do.
Yeah, yeah. We had a big practice, so we would just take one person from the departments to represent, and they would be that part of that improvement team.
Right.
So the meetings would be a smaller number of people gathered, but those people were representing their area of the
Right.
clinical staff. Just otherwise, figuring out priorities for work and what we want to work on first, trying not to be this is what we're working on next directive. Just those conversations on what are we noticing, what are we yearning for, what are we not enjoying, what are we findings going well, and then what do we want to start doing. It's always one of those times when you come in and you're like, here's all the problems, let's fix them all, and having to be dialed back to, well, let's get one or two things underway.
Right.
Build on that to see
That's where a parking lot is handy.
Yeah.
So you can keep a list, getting a list from people, and hopefully they truly are representing the other team members so that they take it back and ask other people. And when we had improvement teams, we always suggested that you need a representative of each key role within the clinic, so that if you are mapping things or listing information, at least every aspect of the patient journey is accounted for in that team, so that you do get different perspectives and the key perspectives, so that you do get the best ideas, and so people can have some input there.
Yeah, yeah. So any other things, examples that you've seen where physicians have done a good job delegating to a staff member a duty that they really were quite um, stuck with figuring out how to do that, or didn't really want to delegate that thing over, but it worked well?
Trying to think of a specific. I mean, a lot of the chronic disease management comes to mind on that, because I think physicians initially were somewhat reluctant. They were used to having patients come back to see them, and over time helping them to understand that a nurse can actually probably spend more time than you can spend to have those, and probably at times frustrating conversations about lifestyle changes and behavior changes. A lot of us can find that harder to have those conversations and have that time within our day. And sometimes it takes quite a few visits and quite a few conversations for the patient change to start to happen. And that's a lot of time of physician time that could be on those new unknown types of visits that you could be doing. And though that's one big one where you've seen in a lot of clinics, where if you've got that nurse that can see, people with newly diagnosed hypertension or diabetes, or where it's just not managed well, having them follow with the team member, and that could be a pharmacist or an OT or someone else as well, depending, what their challenges are. But having those sorts of things, all those sort of chronic things, osteoporosis, teaching, any of those kinds of things can really pull those visits out. Because if you've got, the numbers of people with those types of things is going up, and that's going to put a harder burden on your time as the physician. And so if we can pull those kinds of things out of your visits, and they're time-consuming visits as well. And so if you can pull those out so that you can be more on time and seeing people in a faster turnover for those unknown things, that makes more sense.
Yeah, yeah. I think you're right. Anything that you're saying over and over again, or you've said hundreds and hundreds of
Right.
times, is something you could totally teach to someone else, or somebody else already knows how to teach that
Yes.
to your patients. Yeah.
Well, we had a physician who had a lot of younger or youngish men in his practice, and he realized he was spending a lot of time telling everybody about vasectomy procedures and the prep and what happens. So he recorded himself doing that. And then when he had the patient come in and said, "Yes, I want to pursue that," he said, "Great," and turned it on his computer and left the person to watch while he went on to do something else, because he realized he was saying the same thing. Even if it's once a day, that time could save you that 15 minutes for one other patient, right? So, and they add up. So figuring out, like you said, certain things you're saying over and over again, is there a different way to do that in a group, or recorded, or a handout, or whatever it might be, or a different team member? Any of those kinds of things could work for that.
Yeah, yeah. One of my favorite questions that came out from the primary care network was, who's on your dream team? Like, have a think about the patients you see, the conditions they have. If you had, we don't know where the funding's coming from yet, this is just imaginary. Who would you put in your dream team? Who do you need? Who do you know would add immediate value to either reducing the things you're doing or increasing the things for the patients? And as we did some of this work, we actually were in a position where there was a bucket of money. There was funding for a redesign of the business. And out of those conversations came the hiring of a psychologist through the primary care network, and the hiring of a chronic disease management nurse through the primary care network, because we could divert the patients who didn't have the money for medications, who didn't have safe, reliable housing, to who had significant mental health issues such as new grief or adverse childhood events with ongoing difficulties navigating adulthood, and being able to send those people to our psychologist or our social worker who could do some of the forms that they needed to get access to the funding, then that just required literally my signature or a few
Right.
medical questions and my signature. It reduced the time for the physician so incredibly, and it increased the value to the patient so incredibly. This was a no-brainer. Even having those diabetic patients watched, you knew they were being looked after very well, and you would get those updates from the chronic disease nurse before they would come in for their script refills, suggestions on med changes, those sorts of things. Like, who's on your dream team? If you could really design this again, who would you hire and why? And what would
Right.
you have them do? And then
Right.
can you identify some of those people now? Can you start seeing some of those changes happen now with who you already have, and then that projection forward of how you would design this?
Right. And the only caution I would have, or a thought that I have about that is there some way to quantify that beforehand?
Mm,
So, I worked with one primary care network that said, oh, we need a social worker. And then when they got a social worker, nobody was referring anybody to that person. And so they thought that was on their dream team. But I think if there was some way to even a tick sheet in your office that as you saw that patient, add one, this would have been good for the psychologist. And then you could quantify it a bit so that you have some numbers to back
yeah.
up your feelings. And I mean, within AIM, I don't know, Sarah, when you did it, but one of the things we used to say was feelings are good, but feelings with numbers are better.
Yes.
And so I would just suggest that if there's some way to back that up to be sure that it's not, there was something recent that happened and that's what's at top of your mind, that, oh, that would have been good, but really that's one a year, or
Yes.
is it every day that there's one of those? And so that makes sense to have that team member, right? Just to help you make sure if resources are limited, you want to make sure you're spending your resources where you're going to get the most bang for your buck.
Yeah, that makes total sense, because as we're starting to look at this team-based care, and I think the team-based care is definitely being promoted through Canada, and I expect it to be required in everywhere else in the world, because like you said, there's only so many of the doctors and clinicians,
Right.
and then there's all the patients, and the demand
Yes.
is phenomenal. Um, yes, how do you choose those people to be on your team? And I love numbers, like you said. It's nice to think you've got it right, but we think we have it right, but we don't actually have it right, because if we started, like you said, just being curious with, and we might think it's a social worker we need, but actually the things we want the social worker to do, somebody else on the team could already be doing those things. It didn't
Right.
have to be somebody of that level of qualification to do it. Yes.
Correct. Yeah. It might be that you could get someone else that's already on your team doing some of that work, for sure.
Yeah. Yeah, love it. No,
Yeah,
these are really good things to think about as we're starting to free you up, as we say.
exactly.
Mhm. Found that even we had as reports come in, they get scanned into the EMR, and EMR optimization is always so
Mm.
important.
Mhm.
Hopping across back to Australia, and I'm seeing all new patients. Yesterday I had the example of, I'm trying to trace this CT report had come in of an aneurysm in the abdomen. And I'm trying to decide, have they seen someone about this before? Has it changed in size? And what do I need to do about it?
Right.
Because it's, sitting at that almost critical point. Well, trying to find the letter that was from the vascular surgeon. In the EMR, it's got letter, 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 and I'm literally opening them all up to see who's the
Right.
vascular surgeon. And as I'm doing that, I'm editing it so that I'd never have to do this again for this patient. And then I'm like, I've got to back this up and say, whoever's putting this in the first place, it needs to be done in a way that we know who it's from.
Right. Exactly. And I mean, one of the things I learned when we did our EMR that was always a struggle, and even implementing bigger EMR since then, and I tried to flag for people, is that you know, whatever you put in is what you're going to get out. So if you want useful information, so in our clinic, I said, oh, great. So we're going to be able to know how many mammograms people have had and all that. Well, guess what? The reports that you pull, did the doctor code it as a screening mammogram? Was it a routine mammogram? Just a mammogram, right? There's different ways to call it a mammogram. And so you can't get one report that shows them all in that way. And you don't think of that when you're implementing, but we need in a lot of cases, the whole team to be entering everything the same. Because, and I know people don't like being told, well, you've got to do it this way. But if you don't all do it the same, then you can't pull things out and find it later. And like you said, then you've got letter, or 5 different types of mammograms that you can't get one total report that shows where you're at. And so how do you improve your clinical care if you don't know where you're starting from?
Yeah. Well, that CT result could have taken me 30 seconds with the right EMR
Right.
implementation. Instead, it took me nearly 8 minutes to
Yes.
find out the story of this particular patient and their particular aneurysm.
Right.
And we don't have 8 minutes per thing in our inbox. We just don't.
No.
That is such a time sink that is not required if we've actually done some thinking and planning well up the lane.
Right, exactly. And the EMR use was one of the things that we flagged in our work around the specialty referrals. And, you know, we've got a certain number of EMRs in Alberta. There's a way that those vendors can send the newest forms that AHS comes out with, or the specialist comes out with, whatever it might be. But then how do we know in your clinic that someone's taken the old one out and put the new one in the right place? So you end up using the wrong form that's outdated. You send it, then you get it back saying wrong form, redo, which again takes time looking to try and understand what's missing, what's not there, which one is the right one. And so they get sent somewhere, but there's, again, if you don't have a team member assigned to take all the new things and take out the old things, how do you know that what you're using is the most up to date either? And that can cause more churn down the road.
Well, that's delaying patient access as well.
Yes,
So that's contributing to further potential misses for your patient.
exactly.
I think one of the most valuable things that I had was a dedicated referrals person, and we would do
Yes.
the letter and they would do the form because they would find the
Yes.
most up-to-date form. They'd fill it in, they'd attach our letter and send it. And that was the most miraculous ad because it took so much time off us, especially those specialists who requested that we make a phone call to make sure it was received, and then they wouldn't answer their
Right.
phone. And so we didn't have to do any of that work. Thankfully, that was one of the biggest, best adds to our big, busy team, was somebody who just coordinated all of the ins and outs of the referrals, the rejections because it's the wrong form, they do the right form,
Right.
send it back, all of those bits and pieces that just take up so much time in your inbox.
And there's so many, you know, in the past, I remember making referrals. There were 2 surgeons at the time that did arms, and you could only call them on the 3rd Thursday of the month, and they only opened, you know, 20 slots. So the whole city was on, it was like a radio contest where we started dialing before 9, trying to get through.
Yeah.
And then one of our primary care networks combined the referrals for one big clinic. Well, then that specialist put a different rule and said, well, they were only allowed to take so many, even though it was for a number of doctors. No, your clinic can only have this many appointments. So they shifted the rules again. And really all they're doing, and then, you know, all they're doing is delaying access for patients. But as the nurse, I had to keep a list in my task list in the EMR or pre-EMR. I had to keep those charts on my desk so that the next month, if I didn't get through this month or only got 2 of them in, I needed to know who still needed that for the next time and phone and do that whole thing again the next month.
Yeah, which just
So,
adds so much time to the staff, to the everybody. Yeah.
yeah, it's not a good use of people's time. And if the physicians could just open their thing, or even, we do funny things like only allow patients to phone in for a physical on the first Monday of the month or something. Well, that makes no sense because that bombards your front desk on that Monday, but also Mondays are the busiest phone day of the week. So why would we pick Monday, right? So, or why do we close the phones over lunch? If you have, if you've only got one person, they got to take a break, I get it. But if you've got two, why can't they alternate? And keep the phone line open? Because guess what? 1:00, you're bombarded again. So why not look at when your phones are open and right? Because you can balance that demand and supply at your front desk and make their lives better too. But I've worked in clinics where it didn't make sense, and you could just spread out that workload over, let people book a physical anytime in the month.
Yeah. All right. Well, I have enjoyed this. This has been good banter because we know we get frustrated and we know that we yearn for better. In great news, we're going to be inviting Marcia to our membership so that our members can have a good old chat about ways they can implement some improvements in their own clinical day. So we're looking forward to that workshop. Thank you. Anything we didn't talk about that you want to leave people with before we head off for today?
I just think that there's possibility and there's hope.
Yeah.
And I think it's important for people to know that there are changes that you can make. Change is not easy, but there are changes you can make that could make your work life a whole lot better.
Yeah.
And ultimately better patient care.
Yeah, I think that's so wise of you. Thank you. Yes, there is possibility for change. I love that message.
Sure.
Love it so much. Thank you so much for this conversation.
Thank you.
Thanks, everybody.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have charting champions for physicians and smarter charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.